I'm a general practitioner. Practice started following the CP service and for the March in 2023. I'm looking forward to a good case.
Wonderful. Victor, where are you calling from? Sorry if I missed it.
I'm calling from Ghana in West Africa.
From Ghana. Oh, wonderful to have you. What time is it in Ghana? I'm not aware of the time difference.
It's 4:26 p.m. right now.
Excellent.
So I'm actually currently in the middle of a clinic, which is quiet at the moment. So I'm hoping I don't get interrupted, but apologies in advance if I do get interrupted.
Not a problem. Wow, we're pulling from live clinics. That's wonderful. Well, thank you for stepping up. Nice to meet you both. Rafa, please say a couple of words about yourself. Not that you don't already have great Neuro VMR fame.
Hi everyone, my name is Rafael. I'm the last year medical student from Brazil. I actually have 7 more weeks until I graduate, so it's exciting. And really happy to be here and learn with you all.
Wonderful. Well, Rafa, please, you know the drill. Why don't we start off with just a chief concern and just that little kind of appetizer for this case, and we'll use that as the first aliquot.
Okay, awesome. So this is a case of severe back pain.
Severe back pain. Well, wonderful. Yasmin, do you want to reflect on severe back pain? What comes to mind?
For me, since I have been lately on steps and studying, I will think maybe some multiple myeloma, but that's like reaching a lot, I know. Back pain, any radiculopathy, any disc herniation, if even something as simple as damaging the any articulation, like vertical articulations, I forgot the name in English, and that would be the first. I will ask the patient first if they have been doing something, they had been doing something before the back pain started, anything physical, like start simple, and then I will like keep digging.
Excellent, excellent. Victor, as a general practitioner, I'm sure you see quite a bit of back pain. Please tell us your thoughts and add to what Yasmin had to say.
So yeah, you're right. I do see a lot of back pain, way more than I expected to see out of so usually I see is chronic back pain.
So sorry, Victor. We're having trouble hearing you.
With respect to this patient, that would be unique. With my differential, and for one of the things something okay.
So sorry, Victor. We would love to hear what you're saying. I don't think we can really make much out just because of the internet connection. So sorry about that. Ravi recommended maybe trying to turn your video off. It looks like I actually can't see your video, but well, Victor, if the internet seems to be working a little bit better, please feel free to chime back in. We would love to have your contributions. For the moment, maybe and just let us know if you're able to chime back in. I loved where you started, Yasmin, and I think sometimes you mentioned right off the bat multiple myeloma, and certainly we'll be able to hone in on specific diagnoses. Sometimes people say, you know, at the beginning of these cases, you know, don't go straight to a diagnosis. But I have to say that I disagree with that. I actually really encourage myself and other people that I clinically reason with, that when they first hear a case, it's actually really, I think, important and a great exercise to say out loud the first thing that comes to your mind. Or if there's a top couple of things that just pop into your mind for whatever reason, I think it's a really good way to sort of reflect on where your mind is pushing you. And if you say it out loud, you can kind of, you know, get it out there and, you know, may avoid, you know, being pushed in a certain direction or being biased in a certain direction. It kind of gets it all out on the table. And then you can sort of step back and, like you did, start thinking about some of the more broad categories of back pain and things that would lead you to kind of a broader differential diagnosis. So I really love that you did that. And multiple myeloma, you know, with bony infiltration can certainly be a cause of back pain. And depending on what the rest of the story and the demographic and the age of this patient is, certainly something we should keep on the differential. I'm sure Victor had some amazing pearls to share with us, and maybe we'll see if we can get him logged back in, but couldn't hear much of what he said. Severe back pain and back pain in general, I think, is a really tough topic. And I think if you go down the list of residencies or subspecialties, you can probably get to back pain through every single one of them. Ophthalmology is the one I can't totally think of how you could get severe back pain. But I'm sure there's something that I don't know about. So, you know, my approach to back pain is really broad. And I actually start with, you know, it's kind of a blunt force, very structural approach. Like, what is in the back? You know, what is in and around the back is it maybe a better way to put it. And certainly we're going to get some more signal once we hear where this back pain is. Is it kind of up toward the neck at the articulation with the occiput, you know, or mid-cervical spine? Is it more thoracic? Is it low back pain? Is it kind of diffuse back pain that's not in the midline or paraspinal? You know, I think those are all going to be great questions that can help us get a good start on what to hone in on. But taken really broadly, I kind of start with, you know, the musculoskeletal apparatus, which we can break down further into things like the muscles themselves. So then we have the bones, so the vertebrae and the different articulations, so the joints of the vertebrae. We have the discs and other soft tissues like synovium, you know, making up the joint apparatus. And then you know, the musculature should also include, you know, obviously includes the paraspinal muscles that run along the spine. And then you get sort of into sort of the neuro apparatus of the back, which we certainly always focus on. And there will be lots of questions that we want to ask to see if we can localize to any of those. But those include things like the cord, so the spinal cord, and then some of its component parts that we don't want to forget about, like the conus medullaris, and then the nerve roots, the cauda equina, which, you know, very interestingly, as we know, the cauda equina around L1 or L2 starts, and then you have basically the horsehair, the roots that are floating in the dural sac, and then eventually pierce through the foramina in the sacrum and lower lumbar spine. Of course, the roots, once you're in the peripheral nervous system, after it's left the dura, can cause severe back pain, and we'll look for some signatures of root or radicular pain. So yeah, that's kind of how I break it down: the musculoskeletal apparatus, sort of the non-neuro stuff, and then the neuro stuff. There's, of course, the different spaces that surround, that are kind of mediate between the bones and the musculature and the neuro apparatus. So you have the epidural space. So we'll want to think about different pathologies that can affect the epidural space. And then there's also, of course, the subarachnoid space, which doesn't just surround the brain, but goes all the way down through the spinal cord. It allows us to get our precious CSF through a lumbar puncture. So, you know, can you get severe pain from a subarachnoid space process? Possibly. I would think of something more like, you know, you tend to see when you have something bad floating in the subarachnoid space, you'll often see something more like multiple cranial neuropathies or meningitis. But I wonder, if it could be something, that could cause back pain. I'm not totally sure. And then the last thing that you always want to think about with pain of any sort is referred pain. So could this be referred pain to the back? One thing that comes to mind is gallbladder related pain. There's something called, I think it's called Kehr's sign, which is often scapular pain. I think right scapular pain from an inflamed or somehow diseased gallbladder that can refer to the scapula and can be felt as back pain, usually upper back pain off the midline. I'm sure there are certainly other forms of severe back pain that can be referred from other structures. So that would be probably diaphragmatic pain, pancreatic pain. So we'll want to think about those things. I don't know how they would make it onto a Neuro VMR, but we want to keep ourselves broad. And then one of the things that I heard, definitely in the chat, and I think Yasmin may have mentioned it, are certain red flags. Absolutely, always think about red flags, early in the HPI. So I think people have thrown up some great red flags in the chat, but some of the ones that we always like to think about are, is there a history of malignancy? Have there been signs of malignancy, B symptoms, chronic infectious symptoms, certain features of the back pain? Does it wake someone up at night? All things that we want to look for. Is it non-positional? One of the things that gives us a good hallmark for musculoskeletal back pain is it really associated with movement? And if it's present at rest or very severe at rest or wake someone up in a still position when they're sleeping at night, those are certainly things that we worry about a more malignant source, either from a malignancy or just malignant writ large, just some badness, some infiltrative, often bony source. So far, just to recap, we've Yasmin has introduced some, both a broad approach and laid out some important differential diagnoses that we want to think about. And then we talked a little bit about the musculoskeletal apparatus, the spaces within the spine, the epidural space, the subarachnoid space, the subdural space, and then the neurological apparatus, cord, conus, cauda, roots, referred pain. And then we're going to think about some of these red flags that could make us think about a more concerning cause of severe back pain. And I'm sure there's tons of other things that will come up as we continue to discuss this, but maybe we should move on and get a little bit more of the story. Rafa, you want to take us to number 2?
Yeah, sure. The discussion is awesome. Thank you. So this is a 73-year-old male with a past medical history of significant for advanced prostate cancer that presents to the ED with severe back pain that began 2 weeks ago, associated with difficulty walking. This pain is worse in recumbent position and at night, and has been significantly worse for the last 12 hours. This patient this morning also noticed difficulty walking and urinating, which prompted his daughter to bring him to the ED. When it comes to the past medical history, I already told you, like the advanced prostate cancer, but it was initially treated with local radiation therapy. And this patient also has well-controlled diabetes type 2. For medications, this patient is on metformin. And I'll stop there.
Excellent. Such an interesting background. Thank you, Rafa, for delivering it so concisely. That's really fantastic. Let me just ask first, do we have Victor back? Oh, it looks like I can see you, Victor. Victor, are we able to hear you?
Hi, can you hear me?
We can hear you perfectly now. Did you? Go ahead.
Yeah, apologies for before. I hope it doesn't happen again. So based on this aliquots, I feel like my differentials have been narrowed quite significantly, although I will try and keep an open mind. He's a 73-year-old man, so right away I'm worried about malignancy. And then we go on to see the significant history of prostate cancer. So the first thing that pops into my mind is possible metastasis to the spinal column. And then he could have had an acute spinal cord compression syndrome arise from this, and that's why he's presenting with this sudden difficulty in walking, or this progressive worsening. It's possible that he had the meds and it's been there for a long time, but recently, maybe due to the weakening of the bones, he's developed a sort of compression fracture. If I was to think beyond the rather obvious signs here, the prostate cancer maybe also put him at risk of a hydronephrosis, which is the obstructive nephropathy. Maybe he has kidney issues that have resulted in him having low vitamin D, low calcium, causing the bones to be weak, and that could also cause the compression fracture in the spinal column, leading to neurological issues. But for now, my mind is mainly on the metastasis to the spinal column.
Excellent, excellent. Yasmin, any further thoughts to add to this interesting background?
Actually, like, since they said that this patient had the history of cancer, the first thing that came up was prostate cancer meds to the lumbosacral spine. The first thing I would think about is the MRI right now. But yeah.
Absolutely. I love that you're thinking about kind of how we're going to further investigate this. Let me push you a little bit further. I would say, you know, an MRI of what? What do you think that we would want to MRI? And that kind of gets to the question of, based on this history and some of the features, how might we sort of think about localizing this process?
I know that there are multiparametric MRI to determine, like in high definition, all the soft tissue and bone, especially from the lumbosacral spine, and maybe cross-sectional imaging with CT or PET scan. But just to see first, I would really like to see how is the prostate, like capsule, and if there is any pelvic or distal lymph node involvement. And I would even think of more metastasis, let's say hepatic or metastasis to other places.
Excellent, excellent. You mentioned the lumbosacral spine. I totally agree that MRI would be the right modality to work with at this point. PET scan, depending on different institutions and the availability of PET scan, I think a little, maybe even further down the line, depending on what we found, to see if there was kind of broader involvement of a diffuse cancer process. I love both of your points, and I think we're going to come back to this question of, you know, the specific etiologies. I think cancer being kind of at the top of the list. You know, some of the things that Rafa gave us, you know, this started as severe back pain, progressed to difficulty walking, worse when laying down at night, progressed to incontinence and worsening progression walking and worsening pain. And, you know, the difficulty walking could be from many different things. It could be weakness. It could be a sensory abnormality. It could be an ataxia. It could be, you know, decreased level of attention and altered mental status that can lead to difficulty walking. So that's a little bit hard. I think we're going to get a lot from the exam on that. But this kind of, you know, constellation of symptoms of back pain progressing to incontinence, progressing to potentially weakness or spasticity or some process affecting the the gait apparatus, the ability to walk, I think raises particular concern for some localizations. Do you have either of you have any thoughts about where that might localize to and what you might look for on exam if you were trying to confirm or disconfirm that?
On examination for this patient?
Just the history. What localizations are suggested by this incontinence, difficulty walking, and pain in the back?
I would definitely think about, if I were to do this imaging screening, I will also look at sacral, all the roots, because if the patient has urinary difficulty, we have also to see if it's neurogenic or if it's something physical, if there's something obstructing, if it's just the prostate that it's enlarged and it's not letting our patient go urinate.
Excellent. And I think one of the things we're all kind of looking toward is the spinal cord. So this combination of urinary incontinence, pain, and progressive difficulty walking, presumably affecting both legs. We didn't hear about right leg weakness or left leg weakness, though that could be spinal cord, is really, really tropic for the spinal cord. I think that's really where we're looking at as far as kind of our highest on the localization differential. I think it's kind of interesting, the incontinence just screams spinal cord. Incontinence plus bilateral lower extremity weakness really screams spinal cord. But in this case, I would want to not be faked out by the fact that this person has a prostate malignancy, has had, potentially, I can't remember if surgeries, but definitely radiation to that area. So could just have prostate pathology causing incontinence in the setting of some other process. So we wouldn't want to anchor on the spinal cord. So we would want to think about different localizations that could lead to back pain and could lead to difficulty walking. So some of the things, if you go further down the neuraxis, you start to get into the roots or multiple roots if we're going to be affecting the gait system. So I would think about a polyradiculopathy or a plexopathy. And some of the things that could affect both roots and cord, I think radiation plexopathy, radiation myelopathy are big things to think about depending on the dose and the timing of when that happened. Radiation myelopathy is a really interesting phenomenon, which I don't think is very well understood for the fact that it actually can be delayed after the radiation and it can be progressive. Sort of just like a malignant or an infectious or an inflammatory process, well after the radiation, is finished, it can actually progress throughout the spine. So that's something that is such a weird entity that it's something you really have to force yourself to think about. Radiation can affect, all kinds of neural structures. So you could have a radiation plexopathy, you can have a radiation neuropathy, you can have a radiation polyradiculopathy. So I think radiation as well as cancer infiltration, which you both have outlined so well, are certainly things we need to think about. Going further down in the possible localization, you think about nerves. Could this be multiple nerves affecting, his walking? The incontinence could be a red herring. Probably not. I think, a more unifying diagnosis will be a little bit higher in the upper motor neurons or just after kind of the roots leave. And then you think about, if you have difficulty walking, muscular neuromuscular junction, we'll see on the exam can certainly lead to weakness and difficulty walking, but doesn't really fit with the back pain and the incontinence that we were seeing. Always want to think about the brain, even when somebody has, bilateral lower extremity issues. Doesn't really fit in this case with the back pain in this story, but always just something to keep in your back of your mind with someone who has cancer. I'll take a really quick second just to suggest a really broad approach to neurologic complications to patients with systemic cancer. The way that I like to break those patients down is actually in a 4x3 chart. And this, bear with me for 1 second. So a 4x3 chart. So there's 4 things on the y-axis. There's 3 things on the x-axis. I'll start on the x-axis. the things that can lead to neurologic complications in a cancer patient are, one, the malignancy itself, so the cancer. Two is chemotherapy, and three is radiation. So all three of those can independently or in combination lead to neural locations. So that's the x-axis. The y-axis is four things, and these are sort of four categories in which cancer complications can lead to neurologic presentations of any kind. And there's probably more than this, but this covers most of it. The first one is direct neural tissue damage. So that's direct extension of a cancer that's affecting nervous tissue, either anywhere along the neuroaxis. That can occur by two mechanisms. One of them is direct infiltration, and the second one is infiltration of adjacent tissues leading to compression. So that's number one, and it has kind of a branch point for two things. So direct tissue damage. Number two is vessels and coagulation. So cancers, chemo, and radiation can all affect the vasculature. They can lead to hypercoagulability. They can lead to bleeding. They can lead to cytopenias. Things involving the blood vessels and the coagulation system can, related to cancers or their treatments, can lead to neurologic complications. So we think about things like strokes. We think about things like bleeds. We think about things like vasculitis or vasculopathy. So that's number two. Number three is nutrition. So people with malignancies often suffer from vitamin disorders or malnutrition, or for some reason cannot get the nutrients that they need, either because of side effects of chemo or because of cachexia from the cancer catabolism. So that's number three. And then number four is immunity. So cancer itself, in the form of leukemia, lymphoma, can affect the body's ability to fight immune disorders or to fight infections. Chemo can also lead to cytopenias, which lead to infections and things like that. Radiation doesn't directly affect the immune system. So that one has actually kind of blacked out in this 4x3 diagram. And then the other thing that you need to think about with immunity is increased immunity. So that would be the form of a paraneoplastic syndrome. So sort of dysregulation of the immune system leading to paraneoplasia. So that was a little bit of that's a really broad approach to patients who have neurologic complications from systemic cancers. And then the absolute last thing that I'll say about that, as a corollary to that kind of chart and that approach, is that you always need to think about neurologic processes that have nothing to do with the cancer. So that's the big pitfall that we want to avoid, is we want to think about things that could be totally unrelated to the cancer that could be causing this patient's issue. So, in his case, this could be a slipped disc just because of his age and, of osteoarthritic disease. And this could be a cauda equina syndrome in the setting of a slipped disc. We wouldn't want to miss it. It could have nothing to do with the cancer. Could this be some other kind of inflammatory disorder affecting the spine? Very possible. But could this be some new medication that's causing, some kind of a bleeding problem, coagulopathy, and he has an epidural hematoma that's pushing on his spinal cord? Totally unrelated to the cancer. That's very possible. Could this be a spinal dural AV fistula that happens in elderly men sometimes and can usually happen slower than this? But we always want to keep in mind a broad differential for our localizations, which in our case, cord at the top of the list. And I would say going all the way up the cord, depending on where the pain is. But you can even have cervical spinal myelopathy leading to incontinence and bilateral lower extremity weakness without involvement of the arms. That's a pearl to remember. Okay, I talked a lot, but wanted to go through kind of a broad approach to that. That type of problem in a cancer patient. And I think you both did a great job honing us in on some of the relevant features for this patient. I think we probably have an exam coming. Is that where we are, Rafa? You want to take us to the next step?
Sure. So there are two aliquots. This one will be the exam, and the next one will be a final imaging. Next aliquot. Temperature for this patient is 37, blood pressure 122/83, and his pulse is 104. This patient appears uncomfortable. Oh, he's on VMR. And cranial nerve exam, is unremarkable. And he has point tenderness over the midline spine near T10 and T11. His upper extremity strength and reflexes are normal. His muscle strength in the lower extremities is 3 out of 5. And deep tendon reflexes are 3+ bilaterally. This patient also has bilateral plantar reflexes that are upgoing and a decreased rectal tone and decreased pinprick sensation in both lower extremities, upper to the umbilicus. And another thing that we noticed during the physical exam is that a straight urinary catheterization produces 100 ml of urine. And that's the end of the aliquot.
Fantastic. Fantastic. That's a great exam to work with. Yasmin, what is our exam telling us? Where is it pointing? What are the
I'm
possibilities?
thinking more something sensory because of the point tenderness and decreased something and the sacral roots. So from L, I think a shaft going from L2 to S5. I will think that there is something like something sensorial, as well as the point tenderness of the T10 and 11. If it's localized, I would think maybe there is a process compressing the roots. I don't know if this patient is taking any immunosuppressor. I was thinking maybe an infection, abscess, or that was my first thought.
Excellent, Yasmin. And we'll step back for just a moment. One of the early questions that we often ask about, when we have an exam is, do we think that this is more of an upper motor neuron process or a lower motor neuron process? Do you want to take a stab at that? These features, do they point more upper motor neuron or lower motor neuron? And let me know if you're not super familiar with that kind of breakdown. I'm happy to talk about it a little bit.
Yeah, I would rather, I'm not very sure. I think they will be, if it's feet upgoing toes, it would be like lower motor, and lower motor neuron.
So go ahead, Victor. It sounded like you might have something you wanted to add there.
I wanted to ask if I thought I heard that there was increased tone in the examination. If that was true, then that would make me think of an upper motor neuron lesion. And then the the Babinski reflex, which was done on the foot. I think it can only tell you if it's upper motor neuron. It doesn't give you much information for lower motor neuron lesion unless you have a weakness already and you just want to differentiate between it being upper motor neuron, lower motor. I'm talking a lot, but basically what I'm saying, if your toes are upgoing, that usually means it's an upper motor neuron lesion. But the main thing that I usually use to differentiate between the two is the tone. So if you have increased tone in the limbs, then more likely than not, you are dealing with an upper motor neuron lesion. And apart from, I think there are some cases where you have a stroke and the patient temporarily has flaccid tone, but then later it will become spastic in nature.
That was brilliant. Thank you, Victor. That's exactly right. So upper motor neuron features tend to have things that go up is one, just a trick for trying to remember that. So the things that go up, like Victor said, the toes go up. So you have upgoing toes. We're talking about adults here. It's very different in little babies, which I'm not really qualified to take care of. So a positive Babinski sign, upgoing toes. You have increased or uptone, so usually spasticity, so velocity dependent increased tone in the affected limbs. The reflexes are up, which they are in this case. We have 3+ reflexes, meaning that they're spread to different joints in bilateral low extremities, and we have the upgoing toes. And then you'll often have weakness in a pyramidal pattern. Pyramidal refers to kind of an upper motor neuron pattern, and is a very specific breakdown that we don't have that specifically here. And maybe we'll save that just because we don't have this in exam to talk about at a different time. So at least the reflexes and presumably the motor is pointing toward an upper motor neuron process. And when we talk about upper motor neuron pathology, we're really talking about only a few different localizations, that being the brain and the spinal cord. Victor, you're exactly right that, in the acute phase, or the hyperacute and the early acute phase, or often all the way through the acute phase up to a couple weeks, people can have what looks like a flaccid weakness or decreased reflexes in the setting of an upper motor neuron injury. So brain or spinal cord can lead to a flaccid paralysis in that early phase, but then we'll gradually develop these up features that we see in a classic upper motor neuron lesion, like a stroke or a different myelopathy, some other spinal cord issue. And then there are other things that can fake you out, like if there's involvement of the anterior motor horn cells, in particular spinal cord processes, that can look like a lower motor neuron process, with decreased tone, with decreased reflexes, etc. So I think the reflexes, the motor, like we said, really pointing to upper motor neuron, spinal cord, or brain. Then what do we have in the sensory? We have a decreased sensation up to the umbilicus. So below the umbilicus, which is around T10 in most people, we have a sensory level. So meaning decreased sensation below that level to at least, not sure which modalities, but presumably, light touch and maybe pinprick was checked. Not sure about vibration. That might be useful to know. To think about where we might be in the spinal cord. And then point tenderness over T10 and T11, and decreased rectal tone. So the decreased rectal tone, the sensory level, the upper motor neuron features are very, very suggestive of a spinal cord process, probably around that level, like in the lower thoracic spine. So and then we also have, bladder retention to 800 cc's of urine, which tells us that there's some autonomic dysfunction. So we have sensory, motor, autonomic dysfunction, and we even kind of have a level that's being referred to. So I think we're pretty firmly in the spinal cord at this point. One thing I'll just point out, just coming back to one of the something you were talking about before, Yasmin, is that if we're thinking about the roots, once you're in root land, you are in the lower motor neurons. So even if you're in the cauda equina, which is still in the dural sac, hasn't left out into the periphery yet, you're going to see a lower motor neuron pattern, meaning you're going to have low tone, you're going to have low reflexes, and as far as you can have bowel bladder symptoms, that's and that can look a lot. That is something it has in common with a spinal cord process. But you have to take sort of those other features to think about, could this be, is this lower motor neuron or upper motor neuron urinary retention? All right. So Yasmina talked about wanting an MRI or some kind of imaging at this point. I think MRI is absolutely the right thing. I think including contrast would be something that could be definitely useful when we have things like infection and malignancy on the differential. So I think we're probably going to be getting some imaging. But do we want to, we're running a little bit low on time because we got started late, but maybe we want to, now that we are pretty confident in our localization, maybe we want to move on to the next aliquot. Rafa, can you take us there?
Yeah,
is this
sure.
Is this the last one?
Yeah, it actually will reveal the diagnosis.
Oh, well, then hold on one second. So we might want to think a little bit more and see if we can kind of put our nickel down on what we're doing. So we're dealing with a 73-year-old man, I believe, who has a history of prostate cancer and radiation therapy and has had worsening back pain for 2 weeks that progressed to urinary incontinence and 12 hours of worsening pain and increased difficulty walking, and then an exam that is pointing pretty firmly to the thoracic spinal cord with point tenderness. Some diagnoses have been thrown out already, but Victor, it sounds like we're going to get an MRI. We're going to get some information in the next aliquot. But if you had to kind of put your nickel down on something, or just even a category of pathology that we're going to find, what would you think?
Well, based on everything that we said, I'm pretty sure we're dealing with a spinal cord compression. As to what is causing that compression, it's my main thought is a compression fracture of a vertebral body, but it could also just be metastasis to the spine, that is to the spinal cord itself. That's what's causing the compression. So right now, that's what I'm thinking I'm going to see. I'm either going to see a fracture or I'm going to see this abnormal mass in the spinal cord.
Excellent. Yasmin, do you want to weigh in with your final thoughts?
I am definitely on a spinal cord compression too, because it can also be caused by vertebral metastasis, which was our first thought. Trauma, like Victor said, a vertebral fracture, epidural hematoma, epidural abscess, and it has motor symptoms, the bilateral paralysis below the affected level of the spinal cord, hyperreflexia, the positive Babinski sign. It has the loss of all sensation below the affected level of the spinal cord. So I'm guessing that it's a T10 or issues right there. So, and it also has sphincter dysfunction. So it's definitely a spinal cord compression.
Brilliant. I think I am kind of in the camp. One thing we didn't get a ton of information on, and I don't know if Rafa has any more information on, was the particular onset of this pain. Did this pain come on super quickly, from nothing, or did it, over those 2 weeks, was it kind of gradually increasing? It looks like he's giving me a little charade saying that it was sort of gradually increasing. So we're not getting a perfect story for saying that there was like an acute fracture, like a pathologic fracture because of cancer infiltration, and then acute compression of the spinal cord. However, that could have started off subtle and then worsened over time. That's possible. We're also not getting a great story for another possibility, which would be a spinal cord infarct. We talked about in our 4x3 table for cancer complications leading to neurologic disorders, coagulopathy and infarct. So we're not really getting that story. That should be hyperacute maximum at onset. Infection has been mentioned. We're not getting a ton of signal for infection. We don't have a fever. I don't think we heard about leukocytosis or anything like that. That said, an epidural abscess can be really subtle because it's encapsulated. It's an abscess. It doesn't have to produce significant sort of meningeal or meningitis or other systemic infectious symptoms. Something like a hematoma, an epidural hematoma, could grow over time. We don't know about a coagulopathy necessarily, but we are getting some point tenderness, so that could be pushing on some of the pain-sensitive structures. And then, you brought up this question, Victor, of direct metastasis, to the central nervous system from a prostate cancer. Interestingly, prostate cancer is one that is not common to go to the CNS, meaning directly to the CNS, meaning, direct brain metastases, leptomeningeal metastases to the CSF, causing leptomeningeal carcinomatosis, really uncommon in prostate cancer. I don't know definitively. I don't think it goes directly to the spinal cord parenchyma, meaning an intramedullary metastasis. I would imagine it's kind of in the same category as the brain in the sense that that's not common. It can happen. It can go to the nervous system, but it just doesn't tend to. Much more commonly, prostate cancer will infiltrate the bones, as we have kind of alluded to. So I'm kind of in the camp of saying that a pathologic fracture with involvement of the T10 vertebrae or transverse or spinous processes, giving you that focal point tenderness, and then compression and potentially some edema causing spinal cord compression and a spinal cord syndrome, what looks like kind of a pan cord syndrome, is probably highest on my differential. But, knowing that, in a patient who's had radiation, can have progressive radiation myelopathy, could have infiltration from the cancer, could have a number of other things, knowing that this is still a pretty broad differential as we go into the imaging. But I'm excited to see what this is. And if people don't have any other quick thoughts, then Rafa can take us home.
So this patient had an MRI that showed thoracic spinal metastasis. So the case of resolution was that since the examination showed lower extremity motor weakness, hyperreflexia, and bladder dysfunction, and thoracic spinal metastasis, this patient was routinely diagnosed with spinal cord compression. This patient was treated with IV glucocorticoids. I was reading that it can decrease the vasogenic edema caused by the obstruction of the epidural venous plexus that help alleviate the pain and may restore neurological function, and neurosurgery was also consulted. And another thing that I read that was interesting, that malignancies that commonly metastasize to the spine are the breast, the lung, the renal cancer, and prostate cancers, and multiple myeloma. And thorax spine is actually the most frequent affected level in 60% of the cases, followed by the lumbar spine, 30% of the cases. And that's the end of the case.
Wow. That was absolutely fantastic. What an amazing journey, starting with something so broad as severe back pain, which can touch literally every specialty in medicine. And then honing in based on a great but brief history, getting a localization from many components of our exam, and then talking about a really broad differential for a patient with a history of malignancy, as well as treatment for that malignancy with radiation. Yasmin and Victor, do you guys have any final reflections on this, or do you want to call it a day and just bask in the glory of an amazing job discussing on both counts?
Yeah, for this patient, I think that he's 73 years old. I would discuss what are the benefits of surgery maybe, but definitely palliative care, just pain control, because 73-year-old with metastasis is a very hard case to rehabilitate.
Agreed. This is a very grave diagnosis and progression, and a complication of progression. So fracture leading to compression after infiltration of a metastatic cancer, very severe. Certainly things to think about, in terms of goals of care and the direction of how this patient would want to be cared for. Thank you for bringing that up. It's always something we absolutely think about in real time. Victor, any closing thoughts?
No, really. I just want to say thank you to everybody. Thank you for the case. Thank you for the patience that you had with me. It was really fun discussing this with you.
So grateful to you both for stepping up and leading us through this case. Can we go through the learning points, and then maybe we'll be able to wrap up?
Hi, everyone. Thank you for the discussion. It was great, Yasmin and Marcos. So going for the teaching points, the first thing we need to think what is in and around the neck, the back. We think about the neck, the articulation, the vertebrae, the muscle, the bones, the synovial, the spinal cord, the epidural space, subarachnoid space, and CSF. And thinking about the causes, that can be all that causes, but some disease like multiple myeloma, a metastasis, a malignancy, infections, or a referred pain that can go for the back. And the red flags that could be urinary incontinence, history of the malignancy, history of malignancy, these symptoms, chronic infections, if the patient wake at night, if it's from some movement, some position, and all that make us think about the differential diagnosis, like acute spinal cord contraction syndrome that can cause the difficulty of the walking of the patient, the prostate cancer that can cause hydronephrosis, the metastasis, the osteomyelitis, and the ankylosing spondylitis. And talking about the myelopathic can be delayed or progressive to the spine, and the radiation can affect everywhere area. And the three things and the four things that we gotta think is malignancy, chemotherapy, radiation, and the four things: direction, tissue damage, extending of the cancer, vessels and coagulation, nutrition, and immunity. And the upper motor neuron, it's everything that goes up, and we think about hyperreflexia, positive Babinski, increased tone, weakness in pyramidal, and can be the localization can be in the brain and the spinal cord. So thank you, everyone. We see you all tomorrow.
Thanks, everybody. Have a wonderful rest of your day.